99, about 99% safe spine surgery. So let me begin. For those who have joined recently, I just announced that we will be talking about advances in spine surgery, but I'll be focusing more on the most dramatic advancement, which is the minimally invasive spine surgery. That will be the core of today's discussion. Uh, in general, if we talk about spine surgeries, they have been handled in a very conventional manner for all the decades that we know. In terms of open surgeries, long incisions, using of just C-arm to see the level, and gross instruments being used. There were not even microscopes available earlier. And of course, things like neuromonitoring, CUSA, bone drill, bone CUSA, etc., were not available. But these are all the recent advances that have gone ahead and given us dramatic results, improvement in the results over the past couple of decades, and more so in the past 1 decade. Of these, the most useful, of course, have been the one which have improved our vision in terms of microscope, in terms of endoscopes, and also the micro instruments. They are the ones which have made the spine surgery much safer. But once the safety happened, the people started thinking more in terms of morbidity. Is it going to be morbid? Is it going to be, you know um, uh, you can say, painful? Is it going to be having a lot of infection, things like that? And that is how most of the diseases and treatment has evolved, from first making it safer and then making it less morbid. So in that aspect, minimally invasive spine surgery has taken a major, you can say, jump and development over the past 1 decade. And that has also further been enabled by 3D imaging, which we are now able to do in our OT with help of a mini CT scan, which is known as the OARM. So we'll be discussing this in more detail. And in the end, we can also talk a bit about the robotics. So I don't know how many of the viewers here are surgeons or neurosurgeons for that matter, but they would be happy to know that navigation system, which is something we are very aware of in terms of Google navigation and car navigation, is something that we as surgeons have been using for more than 2 decades now, to help us reach the right spot during surgery. These are the tools which guide us in reaching to the right place, whether it's the brain surgery or whether it's the facial surgeries, things like that. So if there are deep-seated tumors in the brain, we have been using this for a long time. Navigation has never penetrated well into spine surgery, for the precise reason that during the surgery, the spine moves. And that's why we are not able to get the right accuracy of the instruments. What has enabled this from now is that we have been able to now take imaging during the surgery. So we have now devices such as 3D CR and OR, which is like a mini CT scan, and also an introp CT scan. Now, what they do is that they take images during the surgery after the patient has been positioned, and then they give us the data to play with. And that's 3D data, and that improves the accuracy significantly. So there are three broad categories of devices that are used. This is the most crude, which is 3D CM. The image quality is not great, but of course it's cheaper, right? And it doesn't occupy too much of space. Whereas an intraoperative CT scan is the most accurate, but also the maximum radiation and also the most expensive. So OARM sits somewhere between the two, where you have decent amount of image quality, moderate amount of radiation exposure, and the cost is also manageable. So this is something that a lot of centers around the world are acquiring now to enable minimally invasive spine surgery, robotic spine surgery, and things like that. So I just take you through a small video, which is more articulate in explaining what I'm telling you here. For most spine surgeries, we need intraoperative imaging. By imaging, we mean some sort of X-rays. Now, traditionally, we have been using something known as a C-arm for this. It is like a conventional X-ray, which gives us images in 2 dimensions. However, what this OR does is that it acquires images
by rotating around the patient and gives us a reformatted images in 3 dimensions. This allows the surgeon to get much more clarity in terms of where he's operating, in terms of the size of the bone, in terms of the accuracy of screw placement, as well as a post-operative imaging done after surgery to ensure that nothing has gone wrong.
The use of O-arm has revolutionized the treatment and the outcome of spinal disorders. It acquires the real-time data pertaining to an individual's anatomy and assists the surgeon in navigating through spinal procedures with unparalleled accuracy.
In conventional spine surgeries, first the incision is given, and then the muscles are separated, and then the bone is exposed to allow us to see exactly where we are going. So what the DigiNav or the digital spine navigation does is that it provides you a 3D image of the patient's internal structures projected onto a screen, which allows the surgeon to have a look at the deeper structures even before the incision is given. So because of that, we are able to plan the surgeries with much smaller incisions, much lesser tissue damage, much more accuracy.
Its availability has enabled the Neurospine team to perform state-of-the-art, minimally invasive keyhole spine surgeries with more than 99% safety and accuracy.
So this is a revolutionary change from the previous concept of first cut open and then see to now first see and then cut open approach to spine surgeries.
So, minimally invasive spine surgery, as I said, has uh, become much better and much easier manageable because of spine navigation. And spine navigation is uses are not limited to just minimally invasive spine surgery, but also to deformity correction, which means scoliosis, in putting screws in the neck. Can somebody please mute? Yeah. And also in managing redo cases. So what we'll do is we'll take a few examples of cases where we have used spine navigation to help us go beyond just a simple surgery to make it more minimally invasive. So this is the concept of minimally invasive spine surgery now, that when you need to go deep, the you don't need to do much of collateral damage anymore. Muscles don't get damaged. You have special retractors which open internally, and through that you can do your decompression and fixation as well. So this is a conventional open surgery, as I said, first cut open and see, and now it is help of navigation see and then cut open through the port. So this is known as minimally invasive spine surgery, conventional incisions, and now the smaller incisions, which give much less morbidity, much less pain, much less blood loss, and much less chances of infection. These are comparable photographs for exactly the same surgery. So all you have to do is put two screws. And earlier, even less than a decade ago, we had to do these kind of surgeries or open them, gross dose, a lot of blood loss, and now we can do them through a port with help of spine navigation. So this is how it works for a lumbar fusion. One can see here, there was a reference frame, this is the screen, this is the camera, and with the help of projections of the instruments, we can determine what would be the entry points for the screws and make a plan accordingly. Incisions are marked based on the projections of that instrument into the deeper into the skin, into the bone. As you can see, incision has not been made. Still, we are able to see beyond before we make a cut. And this is the reference frame that we use. It's like a camera for the navigation, and through which now we have made a small cut, and we are going to put a guide wire which is going to take us into the pedicle. This is the most commonly used surgery in spine because of degeneration, maybe spondylolisthesis, maybe disc disease, maybe instability. So all these cases now, these surgeries now enable us to make the patient get up the very next day, and this back pain, the leg pain also improve dramatically even on day one itself, because there is not much of morbidity related pain of surgery. The usual stay in the hospital is about 2 days. So all these guide wires have been placed on both the sides, and this is now the other side where we're going to put the port. Port is where we actually do the surgery from. We go inside, do the drilling of the bone, reach the disc, remove the disc, free up the nerve roots, and this is where it's being targeted. Let me just forward it for you, and that's the port, right? So when you done it, you go inside and you dilate it internally, expand it internally, so it gives you a lot of space inside. So this is also known as a keyhole spine surgery. Why it's called keyhole is that just like a keyhole has a small hole, but when you go close to it, you can see a lot. It widens your approach as you go inside. So this is what a keyhole does. Inside, if you go inside, the exposure is much wider than the incision itself. So you're able to get good decompression without the morbidity. These are more technical aspects. We will not go into this. This is just a demonstration of how the instruments placed on the skin can help us find out the size of the cage that's required and what is the angle that's required, all those things, so that everything becomes smooth, pre-planned, and more accurate. So these are the dilators being inserted. Now this is a small short video of how we place the screws. So once we have seen the guide wire has been confirmed location with help of a O-arm shot. You're putting dilators to create some space in the muscles. And once the dilators have been placed, it will be followed by a navigated tap. See, I'm registering the navigation on this reference frame. And we do that every now and then to confirm accuracy. And now we put the tab inside. The tab helps me determine from here what size the screw should be, direction, diameter, all those things, so that there is no error, right? And this is now the confirmation of the size. And now you can see we are placing the screw, and the screw has a 3D imaging here, which is like a 3D rendering of the screw itself, which is going inside, and you can see it in live mode where exactly it is going. So this is what technologies have done now, and robotics does exactly the same thing, except that the robot will hold the screwdriver and it will take the screw inside. So it's very useful if you're planning something like a scoliosis surgery. You've got multiple screws to place, but otherwise the guidance between navigation and robotics is not very different. It's the same principle. So these are a few other examples of how we use navigation to reach the opposite side, find out the facet joint, put the cage, put the screws, just different shots to give an idea. And these are special screws known as fenestrated screws through which we're able to put the guide wires also. Now this is interesting. This is a patient who was osteoporotic. Earlier there was a time when osteoporotic patients could not undergo spine surgery because the bone was so weak. But now we have these special screws where we can put cement through the screws and surround them so that we have a much better grip of the bone, even if the bone is weak. So a lot of patients who were earlier bedbound because of the surgery was considered to be too unsafe can now undergo surgery because of this technology being available. Let me just go back and show you. It'll take a small minute. So screws have been placed. Now adapters are being placed. Now these adapters are the ones through which the cement is going to go. This is checking the patency of the space. The cement is being prepared. And once it is mixed and ready, it is loaded onto each of these small syringes, as you can see here. And this is a consistency that you want so that it doesn't go into the venous system, doesn't go into the lungs. And this is then gradually injected into the space. So once this is injected, I'll just show you one X-ray image where you can understand how it looks like there. So the screw hole becomes much stronger because of these cement augmented screws. All these new technologies are helping us make the patient get up and walk the very next day. Even patients who were earlier considered to be inoperable. This is one example of a cement augmented screws. Earlier we had to do open surgeries for these. But now, as you can see, listhesis has been reduced. This is spondylolisthesis. Cage has been placed for support. Screws have been placed. Cement has been made. So all these give us a lot of longevity and durability. This is an example of an international patient who had multiple level listhesis, severe back pain, very severe back pain. You can see how unstable the spine is. The bones are not aligned. They're moving with respect to one another. In this case also, rather than going for an open multi-level surgery, we did small cuts. And because you're not doing any muscle dissection, the pain is significantly less. The very next day, the patient is able to get up, or maybe in a day more. And this is the kind of fixation you get, alignment. All these things are helped with help of navigation. And this is the post-operative wound. So not much morbidity. This is another patient, multi-level stenosis in the lumbar spine. This is very common. As doctors, you will come across this very commonly, where you have patients who have back pain going into the legs, who cannot walk for a long time, who cannot stand for a long time. They will either have tingling or burning or pins and needles in the legs, or just they have to take break every 5 minutes, 15, 20 minutes, and then wait for a few minutes and then get up and walk again. So very typical of neurogenic claudication. This is called neurogenic claudication, and it's very typical of lumbar canal stenosis. This patient also had same issue, except that there was a lot of tightness around the nerves. So we have removed all the bone, all through MIS, put the cages, put the screws, and this is the minimally invasive picture after surgery. And you see, it looks as if it's something out of the future. We are doing these things now regularly. The mobility is significantly less. One of the major areas where we have it has widened our ability to help the patients is patients who are morbidly obese. You see, earlier patients of this size could not be operated with minimally invasive spine surgery because the X-ray would not show you any bone. It will just show you soft tissue. The imaging was not strong enough to penetrate all this flab, so which we are now able to do through small cuts. So I often explain to my residents also, since I'm a professor, that the differences between digging a pit to reach the water underground, whereas putting a tube well, which is like a tube, small cut. So the fatter the patient, the more they benefit from minimally invasive spine surgery. Because if they were to undergo open surgery, the incision would be really long. A lot of muscle dissection, difficulty for surgeon, blood loss, trying to retract. So this is how we are able to reduce the morbidity even in patients who are 150, 140 kgs of weight. And because of the strong fixation and cement screws, they're able to get up and walk the next day. This is a condition known as spondylolisthesis. At one point in time, it was unthinkable to do these by keyhole surgery. And if I would tell people that I'm going to do it by keyhole surgery, even my colleagues would not believe me, and they would say, no, no, don't get this surgery done by keyhole, go for open surgery. But you would realize, how technology has changed with advancement of these new techniques, that you are now able to do all these through small cut that you can see here. This is the port that we have used to go inside, and through that we are putting the screws, the rods, and also you see now these steps, you're reducing the bone back into its space. And this is how it was preoperatively, and this is how it is after surgery. And all these things are being done through the smallest cuts, same incisions. You don't need to put screws above and below. Otherwise, normally there was a school of thought where it said that if you have something like this, you have to put at least 6 screws, 8 screws, 10 screws. So patient has much less morbidity, good ability, motion preservation. All those things are helped by this technique. Ability to go inside, elevate the disc space, improve the curvature of the spine. So all these advantages, which may be difficult for me to explain you in this class because it's sometimes more technical, but you should be able to get the point. This is another example of how through a small cut, we go inside, we first decompress on the right side, then we tilt the port, you are able to decompress on the opposite side also. Earlier, to be able to achieve this, we would have to go from the midline. So all these are now possible with the help of either navigation or just minimally invasive spine. You can say retractor systems, which allow us to. You see how we are able to see inside? It's the dura. This is one of the nerves, ipsilateral nerve. That's the contralateral nerve. So you can see four nerves through the same port. This is the upper level, let's say L4, L5. And as you tilt your scope, and you can see two nerve roots more. This is after the surgery has been done and the decompression is complete. So all the nerves are completely free, and the morbidity, as you can imagine, very less because we're not doing any major muscle dissection. So we have used now 3D navigated minimally invasive spine surgery and applied it to a variety of problems, starting from degenerative to traumatic to inflammatory, congenital, as well as neoplastic. So we'll just take up a few examples so that people understand what kind of work is being done in our center, in our country, because this is a very common problems. And the biggest issue people face is either grotesque surgeries because the technology is not available, or unsafe surgery, patient becoming worse after surgery because the expertise is not available. So now we have, with help of technology and years of experience, a lot of surgeries, complex surgeries being done very safely now. So the example of a patient who had a collapse of this vertebrae in the dorsal spine, possibly due to some trauma, and there was a significant compression on the nerves, spinal cord, as you can see here. Now the point was to remove the bone. I think it's a tumor case. Remove the bone, put screws, and all this was done using the keyhole procedure. As you can see, the surgical planning here: upper screw, lower screw, midline, and port for the opposite screws. And this is after the corpectomy. Cage has been placed, and all this is being done through the small port. I'll give some more examples. This is a patient with epidural tumor. Epidural tumor is like a tumor which causes compression on the cord, but is not a tumor coming from inside the cord. So this is something that we are able to remove through a small port, go inside, expand it, remove the bone, and then gradually through that defect, you remove the collection or pus or maybe some tumor, things like that. Now, this is uh, fairly common in our part of the world, something known as tethered phylum, which is like a congenital problem with children where spinal cord gets pulled. And this here we needs to be removed. This cut needs to be cut. And this is what is causing a lot of morbidity because it's normally being done by open surgery. And as you can see here, through the small port, we're able to find that tethering tissue and able to clip it and remove it, and all through the scope. So this is again, I don't think this video is going to work. This is an example of various tumors of the spine, one level, two level, inside, outside, inside, outside. All these things are now also being done through minimally invasive techniques using combination of spine navigation and 3D imaging. This is another example of patient with three-level tumor causing significant compression on the cord. And all this is done through the small port. And this is the incision after surgery. And see the kind of access we get inside despite a small cut outside. Otherwise, normally you would have to make a long cut like this. And that's still being done in many countries, but things have advanced significantly. Another example of a big tumor outside the canal delivered through the small port. In many such examples, I'll just take one more. This is in the neck, a small tumor here going right outside the foramen. And you can see here, this is the left vertebral artery. The right one is hardly visible because of compression. And the tumor is causing significant cord compression. So this patient came to us with significant weakness, difficulty in walking, and also bladder bowel involvement. So he had a short and thick neck, and open surgery would involve a very long incision, a lot of dissection, and this is where we decided to do MIS procedure for this. And this was one of the earliest reported cases in the country. Fortunate that I had access to that technology and experience from Cleveland Clinic to be able to use that for this case. And one can see here, we have removed the bone to remove the tumor and then stabilize it. And this is how it looks after surgery. And this is the MRI which was done after surgery, complete removal of the tumor, as you can see, contrast MRI. So this is how it works. So another patient who has something known as OPLL, which means cervical spondylosis with bony calcification, spinal cord compression, as you can see, very severe compression. Now this patient, he had a fall. After that, he is not able to move his arms. His leg movements is also not that good. In this case, we decided to do under neuromonitoring something known as laminoplasty, very minimally invasive, just like a small cut in the bone, open up that space, and this you can see here, many plates put here that allows for expansion of the space. The cord becomes free. This is also one of the first cases that to be done in the country at our center, minimally invasive laminoplasty. This is a cut after surgery. This is, you can see the expansion, how the space is opened up dramatically to allow for the spinal cord to breathe. This is the patient after surgery. You see, this is done after surgery. after surgery, you can see how it's opened up compared to before surgery. So these are just few examples of how technology has taken allowed us to improve patients' outcomes without increasing their morbidity. This is high up in the cervical spine. Patient with some AED is attempt to axial dislocation, where the spinal cord gets damaged. These are also conventionally done by open surgeries, very risky surgeries. Very few centers in the country are doing it, and we are fortunate that we are not only doing them in great numbers, but also doing them by MIS, which is also one of the only centers in the country which is doing this. And all thanks to navigation, because it can guide us from outside what screw trajectory one has to take. As you can see here, I put a port, put a guide wire here, and through the guide wire, I'll just take you through the steps, how you gradually target the C1. And I know it's too technical a bit, but just for you to understand, for your understanding, that's why I kept it very visual, so that you were able to appreciate how through small incision we are able to perform so much, which would earlier require a big surgery, a lot of blood loss, and things like that. So this is a post-surgery O-arm image taken during the after surgery, before the patient is extubated, so that you know exactly if there's anything wrong, you can immediately revise it before the patient goes into the post-op area. So the chances of redo surgeries become very, very less, because you have this tool inside the OT, which you can help you see these images before the patient is wheeled out. This is an example of AAD, cord compression, dislocation, instability, again fixed through similar technique, through small and minimally invasive techniques. Another patient, this is a case of fracture. It's called a hangman's fracture. You can see the bone has dislocated anteriorly. This has gone back, and your aim is to align them, bring them together, and fix them. I have seen centers put screws here, 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 everywhere, because they cannot approach this area because it's very risky. They don't have the experience or exposure. So we were very fortunate that I was worked with Professor Goyal in Bombay, KM Hospital, and also at the Queen's Center in UK, where we learned these kind of techniques, where through small cuts we are able to go inside and put the screws, align it without having to do open surgery. This is what used to be done earlier, and this is what we're able to do. This is a international patient, I think, probably from the African subcontinent, from what I recall. This is, I mean, this goes on. There's so many examples. Now, through this small port, we're also able to put multiple screws. So in some cases, that's the need. We're able to do that for addressing instability. I do have examples of scoliosis also, but then of course it gets very long. The whole talk. Is largely based on minimally invasive spine surgery, so I will not be covering that part right now. The aim was to show you the technology, how it has advanced, and how now under neuro monitoring, with help of good scopes, with help of good detectors and 3D imaging, we are able to do a lot of these things in a much safer manner. This will not work. I think this is an intraoperative CT scan done after we put the screws. Okay, this is something that we are doing new. Even small tumors inside the cord, we are now addressing them through minimally invasive spine surgery, because you see the problem is here. Why punish the muscles? This is AVF, a little more technical, but this is earlier used. We need to do it by open surgery, and now we can do these through small cuts, because the angiography helps us to understand where this point is. So you see, I don't need to see all this. We just need to focus on this, and we can just put a scope here and put a clip, and the problem gets solved, because the angiography tells us which place to target. Right. So I think we'll end here. This is our team, which works in sync with Artemis Hospital in managing all kind of neuro cases, and spine forms a major chunk of this work, including spinal deformities, CV junction, and of course normal degeneration and tumors as well. Any questions?
Hello.
Am I audible?
Yeah, Dr. Rajan, you're audible, and
Okay, okay.
thanks for a very informative presentation. So now we open the meeting for questions. So please feel free. Sir, I have a question because many times when doctors,
Yeah,
because they are not doing minimally invasive surgery themselves, and
right,
I shared in the beginning the context, and they fight the battle of perception. You know,
right,
so how they can answer it? Like, issue comes to them, and it's very obvious that this will help them, but there are fears around it.
right. So, look, in terms of counseling, the biggest, of course, confidence comes from seeing patients who have been operated, right? And fortunately, the internet is helping us a lot in that. So, if you look at the Artemis website, you'll have a lot of patients where they are giving their testimonials in favor of minimal invasive spine surgery, or you can say 3D imaging, where they have shown that they were able to get up the next day, things like that. Other than that, I think it is as the technology percolates in more and more centers, you see more and more results. Things will become speak for themselves. At this point in time, um, one can be told that major issue is still the limitation is the availability of technology. You see, if you I remember when we were in a small town when I grew up. At that time, we used to hear that Delhi had very good hospitals and very good technology and things like that. But it's sometimes hard to believe what can be the limit, right? So the same is the true between India and some of the countries which don't have these facilities. So I can understand that they will find it hard to believe that we are now doing surgeries which are minimally invasive, next day walking, 99% safe. But the world has reached there, yes.
Sir, also many times, like when we're doing counseling and when we use information like 99% success, etc. So I mean that's a very
Yeah.
layered statement, because if somebody is coming to you and they already have some damage which is not reversible, you can fix only to that extent. Can you elaborate a little bit on
Of
that?
course, very important question. So you see, we always need to understand that we have to separate the two things.
The video is gone off.
Okay, sorry. Okay, fine. We have to understand that we have to separate two things. Okay, one is success and one is safety. Okay, success is about improving the patient. Safety is about not worsening the patient. You understand? So when we say 99% safe, it means out of 100 patients, 99 patients will not have any deterioration in their condition. They will not become worse, right? And then we talk about success. Success is a separate topic itself. So we never say that 99% patients will get up and walk. Obviously, if a patient comes to me in a paralyzed condition, there is no technology in the world, that there is no power in the world that can probably make him walk, especially if it's a traumatic. In Norway, in the US also, you will get that result. So when we say 99% safe, it means safety comes first, success follows, right? And success is different for different people. Success is very variable. For example, a person who is a go-getter. He wants that I should be able to run, I should be able to go to the gym. And if I tell him that I will take care of your pain, but you can't go back to gym, he may not be very happy with that success, right? On the other hand, somebody who's housebound, who cannot leave house, he's not interested in running, he's not interested in gym. He's saying, give me the freedom just so that I can leave my home, I can travel, I can feel more independent. So for him, even that much of liberation or improvement is considered to be success, right? So we never say 99% successful. So we say it's 99% safe. Success is variable depending on the preoperative condition of the patient, depending upon how old the disease is, what is the stage of the disease on MRI, and things like that. So you have a very valid point. We have to tell them that these things can be clarified more on one-to-one discussions. That's why we also have online OPDs where we can give them this clarity in more detail, whether how much they are likely to improve, how much they will not worsen. Of course, we are studying them, but how much they're likely to improve.
So then there is one more question, because spine surgery or neurosurgery, it often as a discipline, it often has a overlap with neurology. And many times a patient, let's say they may be developing a spine issue, nerve compression, and a neurologist feels that medication or physiotherapy can take care of to an extent, and till it deteriorates, only then surgery should step in. But then another
Right,
school, that if surgery, it's about mostly when elderly patients develop it, they are in pain last years of their
right,
life. If surgery is done
right,
early, I mean, it may improve the quality of life. So
right, right.
you being a neurosurgeon, so you have idea about both sides. So if you could elaborate a little bit on this, sir. And again, sir, your
So,
bit.
from what I understand, what you're saying is that while the neurologists are recommending medical management, right, and that can work in many of the patients, how do we can tell the patients that no, your case can improve with physiotherapy, maybe exercises, maybe painkillers, but surgery is ideal? Is that what you're asking?
Yes, sir. So how is that determined? Because let's say
Okay, yes.
uh, somebody develops early spine deterioration somewhere in the spinal column.
Right, right, right.
Very clear that okay, medication, physiotherapy, or all that pain management can work as a therapy for some time. But eventually they may require surgery. And let's say it's a
Agree.
elderly patient, 65-year-old female who may require it. But it's also very clear,
Okay.
wherein let's say patient and surgeon, they have high position of trust that
Yeah,
early surgery may improve the quality of life, because 65, you don't know whether they have 10 years,
right,
75,
right.
20 years left, and it may alleviate the
I
pain.
agree with you. I agree with you.
Both of
Look,
which,
in general, if you ask me, um, that's why you find so many variations in the opinions of different doctors, you know, because everybody has a different exposure to the patient's life and to their journey. In general, if you ask me, because it's a very long topic, it's a very big question that you asked. In general, a patient who comes to me with acute pain, which is of a short duration, relatively less than, let's say, 3 to 4 months, and there is no weakness, and the quality of life is not severely compromised, those patients are the ones who will benefit and who should be given a trial of medical management, which includes precautions, posture correction, exercises, physiotherapy, medicines, right? All those things, maybe some injections as well. But on the other extreme, on the other end of the spectrum, we have a patient who has been suffering for a long time, who has tried all of these, but these have not worked, right? Or they work, but the attacks keep coming back. So much so that either they develop weakness of the foot or the arm, handwriting changes, or they develop a poor quality of life. They're not able to travel, they're not able to holiday, they're not able to lift their children, things like that. They're not able to lead a normal social life, um, going for a walk, playing badminton, things like that, right? So when that happens, and we find that there's a corresponding compression of the nerves in the MRI, then of course that's where we have to sit down and tell them that this is the reality of your problem. This is the stage where we are kind of being pushed to the wall, where surgical decompression plus minus stabilization will be a better way to improve your quality of life than to just drag along with the physiotherapy and exercises, especially if they're not working, right? At the same time, we have to appreciate that everybody has different demands from their lifestyle. So I do have patients coming to me, who live on the first floor. They have a shop in the ground floor. They're 70 years of age. They don't have any social circle. They don't want to travel. They are happy with a joint family. There's somebody who's helping them out and everything. For them, medical management is totally okay because that's that's there's not much demand from their lifestyle. Whereas the same person with the same problem, same age group, but a much more social person, A person who says, no, I need to be travel the world, or maybe I'm politically inclined, I need to socialize, I need to meet people, I need to be mobile, right? Those kind of patients will definitely require surgery. So many times these treatments are individualized. That's the reason why you will find so much variation in people's opinion, because some doctors will look at the clinicals, some people will look at the overall picture including socials, some will look at just the examination. Okay, if there is no weakness, you don't need surgery. Whereas other will look at the overall journey of the patient in terms of the deteriorating quality of life. So yes, I agree, it's a very big gray zone, and that will always remain.
Okay. So interestingly, within the month of July, we also have we are also planning a masterclass on pain management with Dr. Ashu Jain. And
Excellent.
with your discipline, neurosurgery and spine surgery, a lot of it are painful conditions. And then we have
Yes.
advancements in pain medications and pain therapies without surgery.
Right.
Like if you can, I mean, if it is, if my question is appropriate or right, and if we can a little bit talk about that,
Why
like
not?
that
Why not?
fit.
So you will be surprised. A lot of patients come to me because of some of
Videos,
the other.
videos banaenge.
Sorry, yeah. So I said you'd be surprised that a lot of patients who come to me, I do end up sending them for injections to a pain specialist, right? And the reason is very clear. Either those patients have no compression on their MRI. If the MRI is not showing much of nerve compression and they have pain, which is not improving on medicines, not improving on exercises, that's the stage where pain specialist role comes in. And Dr. Ashudan will tell you, whenever there is a compression, the only reason why I'll send the patient to a pain specialist is if he can't undergo surgery because of medical morbidity, coronary arteries disease, some end stage liver problem, or if he says that right now I just need some pain relief, I'm not able to come to terms with surgery. So we say, okay, fine, you go for a pain specialist, go to a pain specialist, get an injection, get some relief for a few weeks, weigh in all the pros and cons of both the procedure, and then take a call. Pain medicine and our role are not at conflict with one another. So we are complementary. Understand? A lot of my patients at a particular stage in their disease will benefit more from pain medicine than from surgery. So surgery, just because there's something on the MRI, doesn't mean everybody needs surgery. A lot of these patients, for example, if I find somebody who is obese, relatively poor bone quality, family members tell me, sir, he's never going to exercise, she's never going to exercise, and the pain is intense. In those cases, I understand that injections can only give some relief. We recommend it, but at the same time, start improving their bone health, start improving their muscle mass with the help of protein supplements, and ultimately take them up for surgery. So it's not we are not at loggerheads with pain specialists. We use them a lot in our practice.
Okay. Thank you, sir. Now we have a question from Dr. Okitundu, Dr. Daniel. He is a professor of neuropsychopathology in a medical university in DRC.
Okay.
I mean, he's head of department, so he's 35 years of teaching experience. So
Oh,
his
wow.
is what hygiene practices after spine surgery. Dr. Okitundu, if you can ask, and I know you're a French speaker,
Yeah.
but if you can interact with Dr. Rajan because your discipline is same, so that will make the meeting more interactive, sir.
Mm. He speaks French.
He speaks French, but he
Okay.
speaks English also, but more fluent in French. Dr. Daniel, you can unmute yourself, sir. Okay, so he has typed his question. So, what
That's
hygiene
okay. So,
is spine?
what hygiene practices after spine surgery? Now, I'm not sure which is the angle he's talking about.
Sir,
But if he asks me, how do we make sure that
I
there
think
is no
it's
infection?
about from both perspectives. If hygiene really means hygiene, or maybe because of the French to English translation, he could mean the precautions. You know,
Right.
he has undergone a.
Okay, I'll address it from three angles.
Okay.
One is hygiene means how do you reduce chances of infection. So one, of course, is try to be make it as minimally invasive surgery as possible. Second is give post-operative antibiotics, Make sure the catheter is removed well in time because urine often becomes a major source of infection. Second aspect of his question could be how do patients keep themselves clean? So one is of course regular dressings every second day till day 10 when the sutures get removed, and avoiding going out of the house, avoiding too many guests so that there is no problem. Using sponging as to clean the wound and the body rather than taking a bath, things like that. And the third, I think, angle which Varun you picked up is hygiene. What did we say? Safety? No.
Yeah, so basic precautions like somebody has undergone spine
Oh,
and they start going lifting heavy.
precautions. Okay, okay, right. Very good, very good. Yeah. So this is something that we practice in all our patients for about 3 months. Okay, after surgery, which means no lifting weight, no sitting on the ground, no squatting, no kneeling down, no lifting children for 3 months. So that is the time required for the healing to take place, whether it's a simple discectomy or spinal fusion, right? And in the first 1 month, we discourage the patient from sitting for more than half an hour continuously. After half an hour, get up, take a small break, sit down, and do your work, right? Traveling not more than half an hour continuously, get off the car, take a small break, sit down again. Similarly, in the first 1 week, 10 days, no sitting on the sofa. We no slow sitting. So sitting on the armchair so that one gets up with some support of the shoulder. And the belt should be on. If it's the lumbar surgery, the collar should be on if it's cervical surgery. So these are small things which can help to make sure that problems don't become big after surgery. Um, we get x-rays done every 1 month for first 3 months, and all these get sent to us from the patient through the partner or through the referring doctor, and we have a look at that. We maintain a record of every patient, all the scans, and every after 3 months the x-rays are done every 3 months. So first 3 months every month, and then every 3 months for 1 year. This is just to make sure things are fine, and as the months go by, the restrictions are removed. I hope I'm able to answer the question, even though hygiene is something I could not. I think you're right, French translation issue.
Yeah, so sometimes AI does not do good translation. So contextually, we have to read. So when
Right,
I have a question, let's say hypothetically, there is some athlete or sportsman had some
right.
undergone spine surgery. Now, what you described is normal lifestyle person, but let's say they want to go back to training or practice and
Sports.
sports, and then the load on the body is higher. So this is
Yes.
the Dr. Daniel's question. So how how much is the limitation? I know it's a
uh,
very vague. It can be very vague question.
So, no. We get a lot of sportsmen coming in for spine surgery, so I'm aware of the issue. And there's golfers or cricketers, things like that. Interestingly, sorry, I think there's some network issue. Am I audible? Hello?
You're audible.
Okay. So it's not uncommon. So we do get these kind of cases. It's just that in those cases, once the surgery, first thing is we have to prioritize spinal stabilization. For example, a patient who comes to me with a simple slip disc and he's just an office goer, I have no issues. I'll just do a discectomy. But a patient who comes to me as a sportsman or as a gym trainer or as a enthusiast who's a climber, let's say, for example, he wants to climb mountains, adventure sports. In those cases, I will slightly gravitate towards spinal fixation so that we're able to provide a good stability to the spine. One, right? And that's how most of the sportsmen have gone back to their active sports, whether it's Tiger Woods and a couple of other sportsmen as well. So that's one thing that we that we are able to stabilize the spine well. Second thing that we try is, as far as possible, it should be minimally invasive spine surgery so that the muscle doesn't get damaged much. So these are a few things at the level of the surgery. Once the surgery is done, their load bearing is relatively slow. So I would say for somebody to go back to active sports, it will take about a year. And out of that 1 year, about 9 months will be spent in rehab. Rehab means that you are basically focusing on core training, on your lower back exercises, muscles, so that you have a very strong core to, to be able to take all the load. So this is done always with help of under supervision of specialists who are sports physiotherapists. Um, One could go into the detail of that, but as you can understand, these are very self set protocols and with some variation based on the person's body profile. I hope that answers.
Yes, sir. So there's a question from Dr. Isaiah. Dr. Isaiah is from Tanzania. So thank you so much, sir, for the nice presentation. What is your recommendation for spine health for individuals working long hours in office, which is a very common scenario today, sir? Being seated, and also, sir, other part is heavy weight lifters, and if there is an age angle to it. Hello, Dr. Rajan, I think there is some.
Uh, Sorry, the voice is not clear.
Okay. So basically, sir, Dr. Isaiah,
Fine, fine.
this-
So let's talk about people working for. I think some network issue, right?
yes, sir, it seems so, sir. So basically,
Let me put off my video because that might help.
okay. So, sir, basically, Dr. Isaiah's question has two parts. One is for people who work, spine health for people who work for long hours and sedentary lifestyle, sit for long, which is a very common scenario
Right,
in today's offices, in modern office.
right,
And second is about people who lift heavy weights, like the gym rats, and if and
right.
there must be some age correlation with it. So that's his question, sir. What are your recommendations for
Oh
being
yes, yes.
spine?
So again, this is a quite a it's quite a vast topic. But let's assume we're not talking about extremes. We're not talking about very obese patients. We're not talking about very old patients. But in general, for the range between let's say 30 and 60 years of age, the rules are largely same. Okay, in the sense that whenever they have long working hours, they need to make sure that the posture is correct. Their sitting posture, the support that we give. Let me put on the video. It becomes easy for me to explain. So, in terms of the sitting posture, you have some back support. You have your laptop at a higher end, at a high level. You have arms which are being rested well. You have spine which is always curved towards the back, and also when you're driving you have back support, small things like that. And also your sitting should not be low. Always the angle between your thigh and your knee and your leg should be more than 90 degrees. So the moment you sit low, the angle becomes less, right? This is the angle between your thigh and your leg. So we don't want it to be acute, we want it to be obtuse. So this is important. This will reduce the amount of load on your spine. Apart from that, basic exercises are recommended for everybody, which includes something known as pelvic tilts, leg raises, uh, windshield wiper with the legs. There's also you can say the cobra pose and Superman pose. All these will help to improve the strength of their lower back and allow you for better, you can say, mm, stamina for sitting for long working hours. For heavy weight lifters, a lot will depend upon the disease. So a patient who comes to me who's just back pain, and the MRI is largely normal, I'm not worried. We can get him back to his active weightlifting in a matter of 6 to 8 weeks. Again, a subject more of physiotherapy and exercises than me as a spine surgeon. But somebody who has a disc problem, especially with a prolapsed disc, then weightlifting is practically out for next 6 to 9 months, because it takes about 9 months to sometime 1 year for the annulus to heal if there's a tear. And if you don't take care of that, there are very high chances that tear is going to rupture and the disc is going to eventually come out. So with respect to age, the as I said, guidelines are largely same between 30 and 60 years of age. For the really elderly, they have to be extremely careful that they take extra protein supplements, do some resistance training so that they can improve the strength of their muscles. Right? Otherwise, gradually they tend to slouch, and we don't want that.
So, sir, when you mentioned resistance training, do you mean that if somebody focuses on core or back muscles, so does that support spine, like for the long-term spine?
Right.
somebody has good, like somebody works on their back muscles or core muscles, does that contribute towards long-term spine health?
Right.
No, so that is my question. Does that, or it has no correlation?
Oh, yes, definitely. You see, this is something. Ah, I'm sorry, come again.
Question was,
Hello.
you mentioned resistance training, so in resistance training, what are
Yes.
groups, which may ensure like or increase chances of better spine health, like it's working back and core, or like that.
Okay, fine. So this is, Varun, you'll be surprised. Even when we were training as neurosurgeons, just about what it's been 15, 20 years since I did my this thing, we had very little idea why some people are developing spine problems, other are not. Okay, but over the past couple of decades, things have become very, very clear that it is the major contributor towards spinal problems is the lack of the muscular support around your tummy and your lower back, which is responsible for increasing the load and reducing the strength, right? If you're focused muscles, help of some resistance training, definitely it helps a lot. How many innumerable patients of mine have become okay without surgery by just having that weakness? No weakness, quality of life is not that bad. Early stage, early to moderate stage, they have been able to avoid surgery because of the strengthening of their core muscles. And this is something physiotherapists do wonderfully. Everybody who is at an early stage of their should definitely beyond a certain stage it has a very diminishing returns. We end up having to require surgery.
Thank you, sir. So any more questions? Dr. Miriam, you see a lot
Is
of
my
now, sir, in between, I think there was some network disturbance, so it was patchy. But I think turning off the video helped. Uh, so we have questions from Dr. Daniel Abebe.
I
Dr. Daniel is from
some demonstrate, so I had to
Dr. Daniel is from
start it again.
okay.
Here, tell me.
So we have question from Dr. Daniel Abebe. He is medical director at one of the leading hospitals in Addis. Thanks for the nice presentation. How do you manage a patient with multiple disc prolapses, cervical and lumbar? Is there a chance of less invasive surgery, or is it open surgery that you do? Okay, I think Dr. Daniel joined late. Uh, so the question is: there a chance of less invasive surgery, or is it open surgery that you do for the patients? Which surgery comes?
I'm able to read the question. So
Okay, sir. Then you can answer it.
uh, uh, I understand. Yes. Okay. I think if Dr. Daniel was here, huh? Go ahead.
So I think he joined late, so
Yes, some network issues.
it was about minimally invasive surgery.
So no wonder. If you're recording this now, you can share this with Dr. Daniel, the presentation that I had.
So
As you can see,
we will also share the summary of the transcript. So all the information
yeah,
discussed will be shared with all the participants.
right. Ex- So, Dr. Daniel, I had shown cases where multi-level cervical spine stenosis was also managed by minimally invasive laminoplasty, right? And similarly, multi-level lumbar disc disease was also managed by minimally invasive surgeries with fixation at 2 or 3 levels. You see, now the technology has taken such leaps that we are able to do all these with help of navigation, 3D imaging, that minimally invasive surgery can be done not just at one level, two levels, three levels, but also four and five levels. It's just that we need to evaluate each patient individually. Some patients will not be able to tolerate that longer surgery, or maybe the quality of the bone is not such, or the hypertrophy of the joints is not favorable, and there we have to convert to open, or we plan for open surgery right away. But as our experience is growing, we are realizing that more and more patients and more range of patients can be tackled by minimally invasive spine surgery. There could be limitations maybe around the cost, technology, more expensive implants and things like that. But other than that, limitations are not that many. But if I ask me for a ballpark figure, for one level lumbar surgery, no confusion, MIS. Two level lumbar surgery, no confusion, MIS. For three and four level, probably half our patients go for MIS and half our patients go for open surgery because of the anatomical constraints. Not so much because it's not better. It is still better, but we can't do it sometimes. What do you say about the out? Okay, which surgery will come first? Normally, if patient comes to us with cervical myopathy, if there is a cord compression causing weakness, we go for cervical surgery first. Why? Because we don't want to have his neck in a wrong position while we do the lumbar surgery in such a patient first, right? So we go for cervical first. But a patient who has cervical pain going into the arm, MRI not showing much compression, most of the pain is coming from the back. In those cases, we go for the lumbar first, right? Because that's the kind of outcome they want first to be tackled. The complaints, and then cervical can follow. But usually they are done, if possible, especially if there are three levels, let's say three levels, they're done in the same sitting. So it is immaterial whether we're doing cervical first or lumbar first. Um, if you're doing in different settings, then cervical is usually done first.
So we have a question from Dr. Innocent Zili. Dr. Innocent is from Kenya. Thanks for the
Okay.
question. What is the standard treatment for rotoscoliosis with Cobb angle greater than 10 degrees?
Okay. So for scoliosis and neuroscoliosis, if the angle is more than or less than, greater than, greater than 10 degrees. Okay. So in general, anything less than 10 degrees, we don't even label it as scoliosis. First thing. Anything more than 10 degrees is when we say that the patient has scoliosis. Anything between 10 degrees and 30 degrees is largely safe. It is just observation over repeated x-rays over the years, unless the angle, Cobb angle, crosses 40. So that is usually the tipping point where we realize that this patient is going to require surgery. And if that 40 degrees happens after the spine has completely grown, let's say the patient is now 18, 20 years of age, and it is just bordering on 40, we can still wait and watch. Though we recommend that you should go for surgery, but it's not as if it's a cause, a major cause of concern. Another aspect that we look at, apart from the Cobb's angle, is the spinal balance. So if you see, let me open up the video. Okay, so if this is the alignment of the spine, you draw two lines on parallel lines on either side of the vertebrae, right? And then you find the scoliosis moving out away from uh, the median zone. Once this is, let's say, this is the right and this is the left. Once the right is the risky part. As long as the curve is there within the median zone, it's okay. I know I don't have those images to explain you, but to give you a rough idea, two things we look at: angle more than 40 degrees, and second is the median zone of stability. If this median zone of stability is not compromised and the whole vertebra, part of it is within that zone, it is safe. But if the moment it goes beyond, very high chances that it will progress fast in those cases, we have to go for scoliosis correction.
We have a comment from Dr. Miriam. Thank you, and I greatly appreciate the presentation and insights in your current practice with keyhole surgery. And again, thanks from Dr. Daniel Lebebe. I think, sir, we do not have any further questions, and I think we have overshot the time for masterclass also. With your permission, I would like to close the masterclass. That is okay.
No, sure. If there are no more questions, definitely let's do that.
Thank you, sir. Thanks for taking time out. I know how busy your schedule is, and I have been requesting Aditya to get a meet from you for masterclass.
Any time for you and Aditya, no issue at all.
Thank you, sir. Thanks a lot.
Bye. Everybody have a nice day.
Thank you very much, doctor.